You're on.
Okay, well, I'm Dr. Silber, and I'm a very, very long time friend at the Egyptian Fertility Society. I've been to Egypt over 10 times, and I'm really honored to be able to speak here. And I just wish I were in Egypt right now, but with the whole COVID thing going on, we'll do it virtually. So my first talk is going to be on IVM, ovary transplantation, and then eventually on in vitro gametogenesis. Very exciting science here. But I'll close each talk with some very simple clinical points that you can follow right now in your practice based on what we've learned. First, watch this video. So watch this video.
There's never been any doubt in my mind that I wouldn't be cured of this. Once I found out, I just made up my mind. That's it. You just have to keep taking it one day at a time and just keep that positive attitude and know that I can do this. I will get through it.
It's 8 o'clock in the morning, July 17th, 1997. We're at St. Luke's Hospital. And we're about to do the first case in the St. Louis area of ovarian tissue freezing. Okay, well, I'm Dr. Silber, Sherman Silber, the Infertility Center of St. Louis, and we really have a treat right now. This is Jennifer, who at 24 years of age, I'm right on that, yes, came down with a terrible case of leukemia. Thought she was going to die, but just to be safe, in case she lived, when she did, and was cured, we would freeze her ovarian tissue. So that was like 20 years ago. And this is the first case that we ever did. And we're the only ones right now really actively with a program in the whole United States. And it's been a long time. And we didn't know that we'd be able to transplant the tissue back. And we didn't know if we could culture the tissue. And here she is now. We had her on Facebook Live several months ago. She was happily pregnant. And now look what we have. Now she's 44 years old, if I can reveal that, with a 24-year-old ovary and beautiful baby. What's her name again?
Madeline Grace.
Madeline Grace.
The next video, the same story.
Dr. Sherman Silber, Infertility Center of St. Louis, and I'm here with the most amazing fertility story ever. This is Amy Tucker. I've known her since she was a little 19-year-old girl who was facing death with Hodgkin's disease, a terribly difficult case. And she's got 2 children from her frozen ovary that we froze before she underwent her chemo or bone marrow transplant and sterilized her. And she's now pregnant with twins. She's going to wind up having 4 children from this ovary we froze before she had this life-threatening cancer and was treated for it.
And this is the last case like that, and then we'll go over the details.
The fact that I couldn't have children really scared and frightened me.
2 years ago, at the age of 21, Melissa was diagnosed with Hodgkin's lymphoma. She was told her treatment would include very high doses of chemotherapy.
I thought, I'm young, I can do it. The odds are looking really great for me. Hodgkin's lymphoma, very curable. And then I really started looking into my papers and my books that you get. And I came across fertility, and I burst into tears. I don't have a biological clock anymore. He took it away from me. So when I'm ready to have kids, it's not going to be a problem.
Well, Melissa, this is a fantastic moment for all of us. I mean, when are you going to have the baby?
We are scheduled for a week from yesterday, so six more days.
6 more days, and you look really ripe.
I am very ripe, yes.
So I just thought that I would show those before and after videos for the emotional impact that it really is no longer experimental. Freeze the ovarian tissue before they become sterilized by their chemotherapy or bone marrow transplant it back 20 years later, 25 years later. They've got a young ovary, they get pregnant spontaneously, and they don't even need IVF. And then we'll talk a little bit more about in vitro maturation, which now also is very simple. You can all start doing it tomorrow. So our summary of our results originally from a fresh ovary transplant, we have a 78% success rate with healthy babies. And from a frozen ovary transplant, a 76%. So we have already 30 healthy babies from transplanted ovary tissue, and we don't have any complications from it. So how does it actually work? Well, I'm going to go through some of these slides quickly because we have a limited amount of time, but I'm absolutely happy to get any emails and discuss with anybody the details. And I can't wait till I can actually come to Cairo and show you how we do it. But also, you're all welcome to come to St. Louis anytime. We'll show you how we do it. But here's just a summary, and you can see that these ovaries last for a long, long time. But the actual age of the freeze were young people with cancer. And so it might not be so good if you freeze the tissue of a 40-year-old for breast cancer. But all of these, if you look at these, there's only one patient really, there was even two patients over 30 and 31 and 31 years old, but they were basically young women. And every single one of these frozen grafts worked. 76% got pregnant with at least one baby. So the concept is the primordial follicles, the resting follicles, are all located in the cortex. And there should be 200,000 in each ovary for any teenager before she begins to actually ovulate. Sorry, I want to go back again and show you that the inside of the ovary is just where the follicles develop and eventually become Graafian follicles and then explode to the surface to ovulate. But really, all of those ovarian reserve follicles are in the outer cortex. And we found that it takes 4.5 months for them, once they're recruited, to become ovulated. So we prepare the ovary tissue in a variety of ways. This is the Kuyama method, where we just want to get a thin slice of tissue and we vitrify it. We can also use slow freeze, and both techniques work fine. And you can see the human tissue pre-freeze. This is what it looks like under control. But post-freeze, post-vitrification, you see no difference. We prefer vitrification because slow freeze does kill almost half of the oocytes. But since you have so many oocytes, hundreds of thousands, it really doesn't make any clinical difference. And so we have just as good results with slow freeze as with vitrification. So once we thaw the tissue, we quilt them together microsurgically. And I do think the technique is important. You want to be able to allow them to get pregnant spontaneously with ovulation and not have adhesions. So we use 9-0 nylon to actually quilt the tissue together. Then we put it on the medulla after the old dead cortex has been removed, and we make sure that the fallopian tube can reach any area of the transplanted tissue so they can get pregnant naturally, spontaneously. They don't need IVF. And in fact, IVF is very problematic in these cases. So here's one transplant still working 8 years later. She's 46 years old with her 3 children. This is the one you saw earlier with 4 children for her transplanted ovary. And realize that she can be a 44-year-old with a 24-year-old ovary. And these are very, very fertile eggs. Now, even leukemia is not a problem. You've heard that leukemia is a risk because leukemic cells can have infiltrated the cortex. But what Klaus Anderson showed, and now we've shown, is that as long as you freeze that cortex after their first round of chemo, the leukemia cells in the tissue will all be gone and dead. But you will still have survival of the majority of the resting follicles. And they're going to eventually have a bone marrow transplant to really kill the leukemic cells in the bone marrow. But in the meantime, you've got ovarian cortex that you can be comfortable is free of any leukemic cells. And we already have 6 babies, healthy babies from leukemia patients whose tissue was frozen after their first round of chemo, but before their bone marrow transplant. So this is a very important point. The ovarian cortex tissue is not very hospitable to metastasis because it's just solid fibrous tissue. It's not a common place for metastasis anyway. But then if you do the chemotherapy, the first rounds, you'll kill whatever cancer cells might have been in that ovary tissue, but you will not have killed all the primordial follicles. So here's that patient. She was 24 years old, and there she is getting married at 41 years of age. And there she is with a baby, with her 24-year-old tissue and her husband. And she got through 2 bone marrow transplants, was completely sterilized, but has a healthy baby. And this is our first case, and it was leukemia. Here's another leukemia patient whose tissue was frozen 15 years earlier, and she now has 5 babies from her transplanted tissue. There's her first baby. But now that I think I've made the point that the frozen tissue transplantation is extremely successful if you do it right and aren't just sloppy in your surgical technique, and they get pregnant spontaneously. But now we'll talk about in vitro maturation. This has been talked about for a long time. And we finally have a paper just accepted in RBMO that should be published fairly shortly. And it's so simple, you won't believe it, but it is really simple. And we're basing it all on the principles of in vitro gametogenesis, that is making sperm and eggs from skin cells that our colleague that works with us on all this, Katsuhiko Hayashi, first showed from Japan in mice, that you can actually take skin cells, turn them into stem cells, and you can develop those stem cells with proper culture into functional oocytes, fertilize those oocytes with wild type sperm of the mouse, and you have healthy baby mice. And that's very, very well established. And I'll talk more about that in detail, but later in another talk. But using this principle, what we found is that all you need is any kind of media, ordinary culture media, cleavage media. You don't need special IVM media. And all you need is FSH and HCG, which you can get from Menopure or just from any pharmacological vial. It's very simple, obviously, and you can put the gonadotropins in, and it doesn't really matter what your concentration of gonadotropins are. We've shown that in this paper. It's so simple. You can do that tomorrow. But what is the base? How do we do it? Why has IVM been such a problem for all these years? Well, that's because what you're doing is trying to aspirate these follicles that aren't, you can't even see them on the best ultrasound, that have GVs in them. And so you really don't get them unless you give some adjuvant FSH or adjuvant HCG in vivo. And of course, that really ruins the eggs. You don't want to give any adjuvants whatsoever. But when we have the ovary actually in our hand and we dissect the ovary tissue, we open up these little microscopic follicles and get anywhere from 20 to 60 GV oocytes, and actually some M1s and some M2s. Let me show you how we do it. So we just dissect the cortex away from the medulla, which we always have to do anyway to be able to prepare the cortex for freezing or for transplantation. And you can see we don't discard the media because that's where the germinal vesicles are located, and lots of them are located there. And so then you can see we've beautifully prepared this cortex, thinned out adequately for freezing as well as for transplantation. Cut it into little pieces. We could either do slow freeze or vitrification. We prefer vitrification, and this is all the freezes that say we get from one ovary. But then we look in the media and we can find 20 to 50 oocytes. And actually some of them are M2s and some of them M1s. I'll explain to you how that works, at least in the next talk, if I don't get to it in this talk. But we know this is true from our detailed following of how eggs develop from stem cells derived from skin cells. So you can see a developing follicle there that's developed towards the inside and the resting follicles in the cortex on the outside. So when we do the dissection, we open up these developing follicles and we get the germinal vesicles. Really easy to do. You can do it tomorrow. No special media. Our studies on this are extensive. So here is an immature oocyte. And there we have the next day, later, we have a good M2 oocyte. And we get 35% of these GVs will develop overnight into good quality M2 oocytes. And this is a summary of it, showing that our average IVM maturation rate is 35%. So whatever number of eggs you get, you can plan on approximately 35% of them maturing. And you can see in the FSH HCG column, we used a variety of different concentrations. It didn't matter really. And in the culture media-based column, you can see we used IVM media, we used cleavage media, we used SAGE media, we used Quinn's media. It didn't matter what we use. It doesn't matter what you use. And we understood that to be an expected finding based on our experimental work with Hayashi on in vitro gametogenesis. But furthermore, if you want to look at the next generation sequencing of these oocytes, 64% were euploid. And so that's the same percentage you would get in eggs that you would aspirate for IVF. So the total number of M2 oocytes that we get is similar to the number obtained after ovarian stimulation. So you don't need any ovarian stimulation. And in fact, we used intentionally a variety of different concentrations of HCG and a variety of different media. And we did not really require what's called IVM media at all. It makes no sense to require IVM media, and we'll explain that to you later. And so you can see it's not just us, but Klaus Anderson and Seegers and Brussels and Hayashi all had the same results of a maturation rate anywhere from 30% to 39% with IVM, with a variety of different concentrations in media. So why does it not require special IVM media, and why does IVM really work? And I'm going through this quickly, but you can get much more details on this from our paper that is now in press at RBMO this year. We suspected originally no special IVM media would be needed, and we found out that was the case. So here's why it works. There are many GVs inside the medulla at the medullary cortical junction that have adequate time of exposure in vivo to FSH. That is because there are so many of them. 1,000 per month were recruited from primordial follicles, 30 a day, 4 months earlier. It is so easy to collect many GVs from the tiny follicles when you have the ovary in hand instead of using a needle. And 30% of GVs have already been made FSH for 10 to 14 days. So this study and in vitro gametogenesis revealed the limited role actually of the ovulatory cycle in ovary stimulation. Intrinsic tissue pressure, along with 8 core genes, I'll explain later, is the mechanism at work to control primordial follicle status. And primordial cortical tissue pressure gradient in the ovary in vivo is the main regulator of primordial follicle recruitment and ovarian longevity. In the highly compact ovarian cortex is the key to saving the oocyte from disappearing after the fetal initiation of meiosis. It is also the key to the cautious gradual recruitment every month of a limited number of oocytes to develop over 4 months into finally gonadotropin sensitive antral and Graafian follicles. We don't need ovarian stimulation for oocyte maturity. FSH has already created the GVs with meiotic competence. Meiotic competence of GVs. We only need ovarian stimulation or the ovulatory hormonal cycle for follicle enlargement and either monoovulation or for oocyte retrieval. That is, to get the egg actually out of the ovary. FSH has already created GVs with meiotic competence. We do not even need the normal ovulatory cycle, and we only need ovarian stimulation to get the eggs out of the ovary. So ovary tissue cryopreservation 23 years later appears to be a very robust method for preserving fertility without any need to delay cancer or other treatment because of the time required for ovary stimulation. And you don't even need ovary stimulation. Simple cortical tissue pressure is found to be the key regulator of primordial follicle rest. And the only purpose for monoovulation or egg retrieval is to get the egg actually out of the ovary. FSH-induced IVG occurs actually in vivo, and so the cumulus complexes from ovarian tissue are intrinsically ready for HCG and final maturation to M2s, no matter what the media used. this results in live, healthy babies. Because just having M2s isn't the only proof. NGS sequencing showed these were normal oocytes, but there are enough papers already reported of healthy pregnancies and babies from these in vitro matured eggs. So to understand why IVM works, you must understand in vitro gametogenesis. And my time is up for this talk, so I'll just make a quick summary, and then I will be giving a talk on in vitro gametogenesis. But the summary is you should remove the ovary after the initial round of chemo, so there's no risk of transferring cancer cells. And you should be able to do very simple IVM as an extra benefit to patients who are having their ovary removed and get anywhere from 10 to 20 good quality metaphase 2 oocytes for IVF. So there's two ways you're preserving their fertility. One is natural pregnancy with the frozen transplant, maybe 20 years later. And the other is that you've frozen their eggs successfully and can use them for IVF, and you didn't need ovarian stimulation or any delay of their cancer treatment. So thank you very much for hosting this, and I'll give my next talk in a little while. Thank you very much.